So our next speaker is Dr. Kathy Van Leeuwen. She is one of our surgeons at Phoenix Children's, and she's double boarded in pediatric and general surgery by the American College of Surgeons. And she's been here in Phoenix since 2005. She founded and serves as a medical director of the Center for Fetal and Neonatal Care at Phoenix Children's. She oversees a team of surgeons and neonatologists in the treatment of babies with congenital problems and ensures the smooth transition of infants to pediatric subspecialists. Her research interests in this area involve the creation of evidence-based pathways for congenital diagnoses. She's also the medical director of reproductive anomalies and differences of sexual development clinic at Phoenix Children's. Her research interests in this area started during her training under Dr. Arnold Koren and Dr. Daniel Teitelbaum at CS Mott Children's Hospital in Ann Arbor, Michigan. Her work currently includes implementing shared decision-making tools to optimize the outcomes in these complex patients. In 2022, she was named the Associate Surgeon-in-Chief at Phoenix Children's and tasked with promoting growth as Phoenix Children's expands women and children services in the East Valley and West Valley of metropolitan Phoenix. She's also a Phoenix native and proud to support her local community. She has 3 talented daughters and sings in an all-doctor rock band. And she's regularly named one of Phoenix Magazine's top doctors. And so the topic that Dr. Van Leeuwen is going to talk about today is not a common one that we see every day, but if you add up all of these disorders, it comes to at least 1 in every 500. So every one of us is going to have at least a kid or 2 in our practice with one of these disorders, and the management and the thinking behind it has really changed, and that's what Dr. Van Leeuwen is going to talk to us about today. So there you go, and here's your pointer.
Awesome. Thanks, John. I got my big clock so I can stay on time. So thanks so much for having me. So, the Phoenix Children's team has always been super supportive of me and this work, and that's been extremely helpful. So let me, just the green button to advance. There we go. So I do collaborate with a bunch of centers nationally. You might see a place where you trained up on this slide. So this is not just a Phoenix thing, but a national thing. We're going to talk about differences of sex development, which used to be called ambiguous genitalia. It still is called that. For a while, we kind of got away from the names, and the names change a lot. So try to stay up to date. I'll try to keep you guys up to date. But basically in 2006, a bunch of people got together for a consensus statement. There were endocrinologists and surgeons and actually people affected by these disorders who came up with this term DSD. Patients do not use it, patients do not like it, but in terms of studying things, we got to call something something. And so that's how this all came about. Intersex went away for a while when DSD came out, and intersex is back. So basically, it's anyone born with a reproductive anomaly for external or internal organs. It's a wide range of conditions. And we used to only find this out when you guys were doing your newborn exams, and you were like, oh, wait a second, I'm seeing something I can't really tell, I'm going to refer the patient. Or you get a teenager with amenorrhea, and you suddenly are the one to let them know that their chromosomes don't match what they look like. And that is, I'm sure, terrifying. And then when you send the patient over to us, there's a lot of questions. We try to see them right away. Now we see them before they're born. And that's because the non-invasive prenatal testing is absolutely ubiquitous. It started out to be something just to figure out, do you have aneuploidies, or do you want to know the sex of your baby? What I tell everybody is don't have that gender reveal. Do not have that party, because when you have a non-invasive test that shows XX, and then your ultrasound shows something that looks like a phallus, you're going to have some explaining to do to the family. So we tell people, you never know what you're going to have. So in general, the DSD term has kind of replaced a lot of these older things. Pseudohermaphrodite, hermaphrodite, these are words that are just kind of not used anymore. However, an intersex patient who really has one gonad on one side that looks like an ovary and one that looks like a testicle on the other side, which we still see a lot, those patients might want to use the word hermaphrodite because the public kind of knows what that word means, and internationally that word is known as well. So even those are words that we shouldn't use, I can tell you if a family is using that word to me, I'll say sure, because people might ask, oh, so they're like a hermaphrodite. And I have to say, yeah, they're understanding of that. There's a lot of stakeholders involved in trying to figure out what to do with these patients, and I'm like a spy at all of them. So I am an affiliate member of urology societies, gynecology societies. I stay involved with all of the support groups because I'm kind of considered Switzerland. And I think that's really good for Phoenix that we are considered Switzerland. We're trying to really figure this out. As you guys know, in the past, the gender assignment was made early, and then people just stuck to that. They kept it a secret from the patient, and now we don't do that. So we don't do early normalizing surgery if we can, although it's still legal in 50 states, and patients will certainly seek it out, and it's their right to do that. So more and more, though, families are kind of choosing to hold off once they hear about all of the controversies. Kids have to know their medical diagnosis so they can take care of themselves later. They also have access to their medical record, as you guys know, and that starts pretty early on. And so we need to make sure that we're not suddenly revealing to an 18-year-old, oh, by the way, you have XY chromosomes, and that does happen. So what are the categories we're talking about? These are the main ones, and if I was giving you guys the boards, which I gave the last 2 days to the pediatric surgeons, I am kind of the DSD expert on the pediatric surgery boards, and the only diagnoses I make sure the surgeons know about are congenital adrenal hyperplasia and androgen insensitivity syndrome. And those are pretty easy to remember. We'll go through them. CAH is the most important one because those kids are on medications and they are adrenally suppressed, and if they get in an accident or they get sick, they need stress dose steroids. And you guys are going to see that more than I am. They don't go to surgery that often, but if they do, they need stress dose steroids at the time of surgery. So that's an XX DSD. So when we categorize everything into the DSDs now, we use the chromosomes as well. So that helps us, those of us who study it, to put them in a box. Nobody's in a box really. Everybody's unique, right? But if you have XX chromosomes and you have a difference of sex development, you're probably going to have CAH. If you have XY chromosomes and you have a difference of sex development, it's probably going to be androgen insensitivity. And then there are the true mixed kids, which are these old hermaphrodite, that old name. Those kids have a mixed gonadal dysgenesis features, meaning there's a whole mix of internal and external anatomy that we got to sort out. And then there's kids just developmentally, things went wrong in the pelvis. That's a cloaca or a cloacal exstrophy. The bladder exstrophy kids have a lot of issues. Kids are born without a vagina. That's called MRKH or vaginal agenesis. Or you can just be born with a portion of it missing, and then when you get your period, there's a serious obstruction. So we see those types of kids all the time. We loop all these kids together so that we can take care of them together with psychology, with the various surgeons, endocrinologists, social work, because this is all super stressful to the patient and the family. Okay, so the first quiz question, super exciting. I hope I get some special music. Otherwise, I'll do the music. I can just sing for you guys. Okay, I'll sing for you guys while you do this. Let's see, we're gonna do the newest one we did was Hotel California, which was really challenging. You think you know the words to Hotel California until you try to memorize them, and then you're definitely behind. But that was our latest one. John, have you ever been to the shows, the Rockstar shows?
I haven't been. I've seen some videos.
Yeah, the videos are not good. You should go to the actual shows. Okay, so patient with a non-invasive prenatal screen, so that's happening at 12 weeks gestation, has an ultrasound finding consistent with a male-appearing phallus. So girl chromosomes, male-appearing phallus, what's the possible diagnosis? Do I advance it, John, or do you? Oh, nice. Desert highway, let's do it. Cool wind in my hair. Okay, well, anyway, you guys will go to the show. It'll be good, yeah. All right, so you guys got that one right. So this is easy. It's also, I think, really important because the family's going to be stressed. They might have other kids. They're in your office. This kid is in the cooker, and they might be asking you some questions about this. And the answers are, this is going to be a beautiful baby, and we're going to make sure this baby gets awesome care when they get born. But they are definitely a challenge when it comes to their regular care. All right, good job, everybody. All right, so again, these are just kind of the answers to that. We'll skip through that so we can go back to the patients. So that's the most important newborn DSD is going to be CAH. So a little bit more about that. There's a missing enzyme in the most common form of CAH. So you end up with too many androgens. And so how do we diagnose that in the newborns? They have an elevated 17-hydroxyprogesterone level. And then they'll get chromosomes showing XX, and we'll be able to do an ultrasound showing that there's a uterus and ovaries. On the outside, they look like maybe have a small phallus. And then often, they don't have a separate urethra and vagina. They have one opening called a urogenital sinus. And that's going to be an issue, because in the past, we used to open that up within 6 months, do reconstructive surgery to open up the vagina, and do something to the clitoris. They used to either reduce it or recess it, kind of tuck it back. So now we let the family, and this is where the vaccines differ from this, we do true shared decision making. I want to know that I'm giving you all of your options as a family. A lot of times the grandparents are weighing in on what should be done, and you can choose a complete reconstruction of the clitoris, but again, most of the families are not choosing that anymore. And we started this process about 10 years ago, a true shared decision making process. And I will tell you that I just pulled the data. It's about a third of our patients are still choosing that full reconstruction. If they want it, they have to go to a center of excellence for that. It's called a CARE Center of Excellence, and they're all over the country. And there's actually not one in Arizona. And part of that is because I'm sort of a champion for everything and the guardian angel of all your girl parts and your boy parts. And so I can't also be sort of changing them dramatically. Phoenix Children's is super happy with our approach. I've sort of become the teenager reconstructor. And so I kind of partner with those folks who do the newborn stuff. But this is extremely controversial and not something that you guys will be too involved in. But when you're doing a newborn exam, in that, I don't know how many of you go to the hospitals to do that, but this is what you could see with a patient with CAH. And you can see on that last one, that patient looks like a pretty normal phallus in a way with scrotum. So there's not going to be any palpable gonads in there because the ovaries are up on the inside. If you do a genitogram and put contrast up this little single opening of the urogenital sinus, you're going to see a bladder and a vagina. And so that's not open on the outside. And at some point, it probably needs to get open. So how do we sort out what happens? We watch them as they potty train. We try to figure out, are you obstructed? Is your bladder getting too big? Are you having hydro? If so, we're going to do like a minimal procedure, like to open up the vagina, but not do anything to the clitoris. Most of our patients are choosing that. If they have voiding difficulties, we do a small surgery within the first few years of life. Some families don't have any voiding difficulties, and those kids are getting nothing. So then they would maybe need something when they get their period. And so that's been the issue when I first got this was presented to me as maybe we shouldn't do so much. I said, well, what about puberty? What about when these kids get their period? So the answer is some of them are fine. Like we've met kids with no surgery, and they say I just pee blood once a month. And some of them actually prefer it because they just go to the bathroom, blood comes out, and then they don't have pads, they don't have anything, which is really like that was a shock to me that would be possible. But we do tell families all of that. If you were obstructed in the teenage period, then we either have to suppress your menstruation while we figure out what we want to do, or you'll need a procedure at that time. And teenagers do not like surgery. I just want everyone to know. They hate it. In fact, that's the word they use. I hate the idea that I would have to have surgery. So the ones that did have surgery as newborns, when you ask them later, most of them are pretty pleased their parents just went for that when they were children, when they were babies, so that they could get that over with. So it's a whole mix of how people feel about this. Okay, so this is, I think, is this a freebie? Yeah, this is a freebie audience response. So you have a patient treated with hydrocortisone and fludrocortisone, and they come to the emergency room with signs and symptoms of appendicitis. This is a 10-year-old. So an important part of the treatment is going to be antibiotics and stress dose steroids. So I'm going to go with A and B. Yes, A and B. So we do have to treat the infection, but we also have to stress dose the steroids. And these kids will get sick. COVID and CAH was not a good mix, I'll tell you. Those kids were very, very sick in the hospital. Okay, let's jump on to some of the other things you could see in a newborn, although you guys probably won't see this as often. So mixed gonadal ambiguities, these are the true half and halfers, as I call them. You can have just Turner syndrome, you can have Klinefelter syndrome, or you can have mixed gonadal dysgenesis. So when we're trying to sort out the MGD kids, we divide them into what's on the inside and what's on the outside, and we just take our time. So this is what these kids can look like. If you saw a newborn like this, I mean, first of all, I would think it's either just, maybe hypospadias, but if you can't feel any gonads, and a lot of time the gonads have not descended, then you have to kind of start going to search. This is almost always going to be like an XY male with undescended testicles. But when you look on the inside with the camera, you can see on that top picture, that's called a streak ovary. And then the bottom picture, that's probably a pretty normal testicle. Streak ovary is a weird term. It looks like a slivered almond is how we describe it. It's probably around the same size. I was taught to take those out. So if you're going to raise this kid as a boy, you would take out that little slivered almond ovary because it's, quote, a streak and not going to do anything. I don't know if it's going to do anything or not. So I just tell families, let's hold on to everything as long as we can and see if we can let this kid kind of decide who they are, and then we'll go after those gonads. That being said, there's a cancer risk. In this particular population, there's a cancer risk. So once we take pictures of everything and know the anatomy, we try to just raise these kids, and then we assess that cancer risk. And so how do we do that? Well, one thing is, like we said, we want to hold on to your gonads as long as we can. We want to look at fertility potential. We want to figure out who you're going to be, and are those gonads going to make hormones that are going to be useful to you? Well, if they look like actual structures that are recognizable, you have a lower risk. If they look odd, and a lot of them do, then you have a higher risk that that's a true dysgenetic gonad that's going to turn into a cancer. So I'm going to put you into high or low risk based on what I'm seeing. And then if you're in high risk, we're probably taking those gonads within the first few years of life, 2 to 3 years of age. If not, if it looks like this was something that was making regular testosterone after birth and it looks normal, we're going to put you in a lower risk and we're going to keep it. All right, we want you to get ready. What other song should we sing? We know Journey, Don't Stop Believin', if you want to find it. Okay, so this is a patient with mixed gonadal dysgenesis, normal testosterone level in that first few months of life, one fully descended gonad on the right and one non-palpable on the left, no uterus. So is this kid low risk because one gonad is fully descended and differentiated? Is it the kid high risk because of the patient's age, 2-month-old, high risk because there's a streak gonad on the left? You can tell my questions are pretty easy. There we go. Living in a lonely world. He took a midnight train going anywhere. You guys know this. You could sing along. All right, so high risk because of the streak gonad on the left. Well, it's mostly low risk because of the fully descended gonad, but I agree with you. We got to take that other one out eventually. But if you have a testicle that's acting like a testicle in one of these kids, it's descending into the scrotum, it's making testosterone, we're keeping it. And now that it's down in the scrotum, we can manage it just like any boy who's at risk of, a testicular cancer. You can palpate it. Now you can feel for cancers. But you're right, that one on the inside is probably going to have to go because I can't feel it, and I'm probably not going to be able to image it. Okay, so let's move on to cloaca real fast. So these are a complete disaster. Kids are born with either one opening on the bottom or everything exposed. And this takes a long time to get these kids kind of back on track. We have a whole team of people, and it's kind of like a slow reconstruction in the first couple of years, followed by many years of following them. What about kids born without a vagina? So this is, kind of a shock to most families. I'll tell you that most families with this do not know about this diagnosis until they're teenagers and they don't get their period. And everyone is shocked that they're looking at the bottom and don't recognize that there's no opening there. It's not shocking. And they'll say, how come no one notices during my well child exams? It's because you guys aren't going up in there, first of all. That would be weird. Second of all, in the OR, when I put these kids to sleep and I show them, I show the residents and everybody at the bottom, I say, is there a vagina there? And they all say, yes. When you just look at the bottom, it looks like there is, because all the hymenal tissue and the folds are there. It's just, it doesn't go anywhere. And so they have a little dimple. And the treatment for that now is to just dilate that dimple. It's kind of stretchy tissue. There's still some cases where we would do a vaginal surgery to like make it a little bit more of a dimple, but in general, we don't. They have normal ovaries. They don't have a uterus. These are the kids who can get a uterine transplant, which is being done in Texas, actually pretty successfully. So you can donate your uterus to someone and it gets put inside with the baby in there. They grow the baby and then they do a C-section. They take out the uterus and the baby. It's actually amazing. And when the people in Texas asked for donors, guess like how many people offered to give up their uterus? Tons. Tons of people like, take my uterus. Because it started out with just moms donating them to the daughters, and then they just asked for donors in general, and they just were overwhelmed with people donating their uterus. So you can have mine, that's for sure. So what do? We do this perineal dilation. So they use dilators, they push a channel. It's tricky. You don't want to be in the urethra and you don't want to be in the pooper, so you gotta just be like right in the middle. We tell them too that just coital dilation works fine. So what I'll do is I'll give them the dilators, and then these kids are older, right? So they're like older teens. And first of all, I have 3 daughters. One's non-binary. And if you tell me that you're supposed to tell your 16 and 17-year-old to just like go for it to make a vagina, I'd be like, not my 16-year-old. But that's a whole nother, I'm very strict. But we do tell them to just, that might work better, is just coital dilation. So they show their dilators to their partner, and then they just make it anyway. Okay, so that's MRKH. Those kids get really stressed about not having a vagina. They're pretty cool about it initially, and their moms are in tears, just crying. And so I can usually get them through that grief in the first year or 2. Androgen insensitivity is fascinating. And you guys, these are the XY girls, as we call them. So there's a variety of causes and phenotypes, but in general, we might make this diagnosis in another surgery. We're doing a hernia repair, out pops a testicle. We're like, that's when I get a phone call. I don't care where I am, I could be out of the country. People are calling me, I need to talk to you right now. We're in the OR. I want to FaceTime you and show you that I'm taking care of a girl and she has testicles and I don't see a uterus, and what do I do? And I say, well, repair the hernias, leave the gonads in, and go talk to the family, and then I'll have my coordinator talk to the family today. And then we just go from there. But these patients might be in your office with amenorrhea. So if you get a girl who doesn't have her period, she's 15 years old, and everyone's saying it's normal, That's true. My kids, it was delayed too. But you're gonna wanna check chromosomes, and you probably wanna say, hey, there's a couple weird things that can happen, including your body did not respond to the blueprint that it was given. And it might have even been given an XY male blueprint, it just didn't do that. And obviously your daughter didn't follow that, and that's the answer. These girls feel like girls. I have never, well, I wouldn't say never. There's maybe one XY androgen sensitivity kid I met that doesn't date men. I don't know if you guys saw this recent Pew research about kids 18 to 25, kids, everybody's a kid, and these are like adult, 18 to 25 young people, young adults, are asked like, are you straight, are you gay, how do you identify? And 28% of them identify as not completely straight, which would, I'm saying it that way because I have daughters in this age, and that's probably how they would say it. So they're gender fluid, who they date is gonna be fluid. It used to be 1 in 10, now it's 1 in 3. So just be aware that everyone coming up behind us is very used to this idea that you could have these chromosomes and feel, female, but you also may date whoever you want to date. So there's kind of no blueprint to tell the families what to expect. So what do we do with these kids? Well, eventually their gonads may need to come out, but we were taught they had to come out around the time of puberty, and we kind of changed that narrative after talking to the families. So the patients themselves, when we took their testicles out after puberty, this diagnosis would come and everyone would say you have to get these out because they might be cancerous or they could turn into a cancer. We looked into that, and the cancer risk is super low, and the patients feel terrible when you take out their testicles. They go into menopause, basically. They have hot flashes, they can't sleep, and they told us they're literally miserable. So we quit taking them out, and we just figured out how to image them and watch them. And there are two main centers that like spearheaded this, us and Children's National. We do it together and we follow these kids with imaging and they do fine. So that was this management protocol, which got a lot of attention and was, I think, really kind of a game changer for this patient population. These women feel great. Like whatever mix of hormones is actually happening, so they have tons of testosterone and it gets converted in their body to kind of an estradiol. So they feel very female. They also have no axillary hair, pubic hair, and no acne because they don't respond to androgens. And if you told them all this is a benefit, they would tell you no, like those are not benefits. But it does make them feel very sort of girly. So they're kind of like supergirls, which is odd, right? Because they have XY chromosomes. Okay, so this is another audience response. It's dealer's choice back there for the music. I don't know everything, but I do know a lot. Okay, so you have a 16-year-old, identifies as a girl, has normal breast development, normal external genitalia, no period. Lab workup includes a karyotype that reveals XY. Panic. Ultrasound of the pelvis would most likely reveal. So what's in this girl's pelvis? So it's a normal uterus and bilateral gonads consistent with ovaries, absent uterus, bilateral intra-abdominal gonads consistent with testicles, or a hemiuterus on one side and different appearing gonads on each side. Ooh, funky. Oh no, that's the, yeah, I don't know this one. Yeah, no, this is the, yeah. All right, very good, very good. Taught you guys well. Okay, so again, they're bummed out that they don't have a uterus, they don't get a period, and they're keeping their testicles, so they're happy. So these folks, the question would be, what could you do with fertility? And so, they're carrying an androgen receptor gene defect. And so that's the one issue, but can you save their genetic material and potentially use that to make a baby? Yes. So the idea is that we're gonna, no matter what we take out of these kids, we save it now. And none of this has been successful yet, but 10 years from now, 20 years from now, we're gonna cook up these babies in a the fridge or whatever anyway. And so I think saving genetic material when you can is the right thing to do. And we work with a team in Chicago that saves all this material. All right, good job, you guys. So, oh, Christina, nice job. So, and that's just the rationale. All right, let's just talk about obstruction real fast. So this is an interesting one. If you see a kid who has a solitary kidney, and there's a lot of these, right? So the prenatally diagnosed with a solitary kidney, or they come to your office and you end up finding out that they have one kidney. They could, if it's a girl, they could end up having an obstruction on that side that the kidney's missing. And that's called ovira, which was an old, I think it was like Oak Ridge Boys, Ovira, but it's Elvira. But I don't know if you guys remember that, a couple of you guys. So anyway, so keep in mind that this is something that they could have an obstructed hemivagina. So we watch them for that if we know ahead of time. But if they come to the emergency room as a teenager, they didn't know they have a solitary kidney, they didn't know they have an obstruction, it becomes sort of an emergency. But those are just XX females. The important thing of all of this is no secrets and disclosure. We talked about gender and how much has changed. That's helping me. I would say when I went through medical school in the 90s, it was not this way yet. And so time has helped me take care of these patients because everyone just sort of gets it. And the families that have someone in their family that doesn't quite fit their gender, they certainly have an easier time waiting to do something for their kids. We do use these shared decision-making checklists, and this is what keeps us on track, and this is how we can kind of study it. But we just start by educating these families and telling them what they need to ask us because they don't know the questions, and so we give them a whole list of questions. We also really encourage them to talk to other people that have the same diagnosis as them, and we have what's called DSD parties. We just had one on Saturday at the hospital at the Cohen Center. It was super fun. And we have like pizza and Chick-fil-A and a lot of games for the little kids, and then all the teenagers are running around. And you just see tons of just great looking kids, like super happy, healthy, and the families talk to each other. We have a whole dad section because dads get super stressed about this and sometimes get excluded since a lot of these kids are identify as female. So what procedures would we do on the teenagers? We're not gonna do anything on the babies if possible, just medically necessary stuff. So for older patients, it's usually also just medically necessary stuff. they're not coming to us asking for gender reassignment. They're usually pretty used to their anatomy the way it is. They don't want a lot of changes. And so most of the time we're just doing things that are opening up obstructions and things like that. And so a lot of people ask me about that, like if we choose a gender for a kid, do we have to redo it later when they go through puberty or something? The answer is no. These kids are just raised as who they are. That most of the time that's what the families will describe them as, is they're just Sammy, or that's just, you know, whoever it is. They just use their name and they don't really put them into a category, which I think is a great solution. This is something we use if you are going to be a teenager with, you know, who's getting reconstructive surgery. We check to make sure you're sure. We use a sure test. And if you're not ready and you answer no about being clear about risks and benefits and understanding your choices and understanding who's supporting you, we just hold off and we keep educating you. Okay, here's another freebie, and this is about sort of shared decision making. But so when different care plans are possible, patients benefit from shared decision making. Understanding the disease, involving important people. This process is expected to take place during one office visit. It's expected to reduce decisional regret. It's expected to only be helpful for adult patients. The answer is it reduces decisional regret. And that can be studied, and it doesn't take one office visit, it takes years. And that's fine. So we have to be devoted to these families as they grow up. And it's hard. I tell John all the time, I'm just gonna quit. Like when it just gets too hard and too controversial, I'm like, that's it, I'm out. And for that reason, I'm out. No, that's another reference for you guys. But I'm not out because I'm the person that these groups need nationally. I'm Switzerland. I'm helping everybody kind of, you know, not be mad at each other. So how do we educate people about sexual health? This is our latest thing, is one of our researchers did sexual health training. So we start with a cultural context. Our Hispanic patients, our Native American patients, our white families, our black families, these are all coming from different, you know, ideas on sex. And so we have to start with the cultural context and asking them. And then we get to a formal evaluation of their stressors and their knowledge and their resiliency. We ask them about how they're doing. We ask them about food insecurity, about their marital issues. One of my colleagues nationally hired a marriage counselor into his practice. So just because the families are, with these diagnoses, especially cloaca, the divorce rate is almost 100%. And so he just thought, okay, I'm gonna just start there. Like, okay, but you know, I mean, people are gonna respond to stress in different ways and we need to give them the tools. On Saturday at our DSD party, we had a talk on coping. And then we just all went around and talked about what we do to cope. I shop. That's a problem I have with coping. I guess I sing too. The first times that you're talking to kids about sex and about their body are these teachable moments. That's going to be a book that you're reading at night. It's going to be when you're potty training, when you're picking out swimsuits. For us, that was the case. So again, 3 daughters. My oldest is non-binary, River. Used to be Annie, now River. Goes by pronoun they. Takes a lot of practice for an English major to use they. But I got it. I got this. So when they were little, we would go to Target and pick out swimsuits. You know, they outgrow swimsuits. And my other daughters would go to the girls section and no 2 pieces on a 3-year-old. No, like why? Just 1-piece suits, that's it, with a swim shirt. Cannot wear a bikini when you're at 3. Again, strict. But for River, I would take them into the boys section and just let River pick out whatever they wanted because River didn't feel comfortable in the girls' suits. So these are clues to mom, right? This is how we're gonna do this going forward. River had a beautiful suit for prom that I had altered at Nordstrom in Scottsdale, and they did a great job of like making us feel welcome and making us feel like this was a good experience and fun. And I was so happy. I told the manager, you guys are awesome, because that in general does not happen to us. So these moments, I think, can, like the swimsuit informed the prom suit. Like you can kind of figure out what's going on. In middle school, these kids get human growth and development classes starting in 4th, 5th grade. They learn about HIV and infections, and then they learn about puberty. If your patient doesn't have the same parts as the other kids in the school, they need to be empowered before they hit that class. So I want them really knowing about their anatomy so that they can ask their parents, hey, that doesn't apply to me, right? And it's a good time to think about it. Coaches are universally very cool about this. You would think they wouldn't be, but in general they are. They just need a little information. And so this is an issue because some of my kids are very athletic, and if they have interesting chromosomes, then we have to kind of sort out with the coaches what's going on. You guys see all that in the media. Dating is then an assessment, again, of your anatomy and your function, understanding how your body works, not being fearful about these first experiences, which is difficult, but we start talking about it. And then making your decisions without your parents. You know, like you guys are used to kicking the parents out of the room at age 14. We don't do that. The surgeons are just so not used to that. And so we had to, in our clinics, get used to that, like kicking people out. So in general, I just want to make sure that all the issues are covered, not just the surgery and the anatomy, but like just your resilience and your coping skills and who you feel like you want to be. And then use a team that includes psychology, which I know is really hard, but it's really important. And then there's no need to feel insecure about not understanding these diagnoses. You have my slides, so you can always like look back. But families just want to see the future, and they want to see that they have a healthy kid. And so the best thing would be to introduce them to other people with those diagnoses so they can see that kid's fine. That kid went to college. That kid ended up doing all the things that their parents wanted them to do. And then I think we can be hopeful about advances in fertility, which is like a really cool field. So this is my email address, and I really, if you guys ever have a question, I get emails all the time asking, you know, for a phone call to kind of figure out next steps. And then I also keep track nationally on what is near you in terms of a really good DSD center. Sure. I'll stick around in the break if you have questions.